Hi, everyone. My name is Haley,
And this is Laura.
and welcome to the Body Pod. Dr. Jocelyn Wittstein, welcome to the Body Pod. It is an honor to have you here. I've been counting down for this episode.
Oh, well, thanks for having me. And you got my last name right without even asking.
I figured it was 50-50. I was like, I'm going with Stein, and
I
that's how
answered to
I would read
either,
it.
but you got it. Yeah.
Yay.
Good job, Haley.
Starting off on a great note.
Yeah.
Hey, Jocelyn, can you share a little bit about your journey from collegiate athlete to orthopedic surgeon?
Sure. I mean, I think most orthopedic surgeons will tell you sports are like the gateway drug to orthopedics. It's just kind of, it's a little bit of a joke. Like, most orthopedic surgeons were some sort of athlete at some point. But I do think that people who have a history of participating in sports have some like ongoing appreciation of musculoskeletal health and preserving musculoskeletal function. And like personally, I'm a subspecialist in the field of sports medicine, but even my partners who are people who are replacing joints, and not preserving those joints but replacing them, are preserving people's function. And I think anyone who's been an athlete in the past just has that desire to keep people physically functional, or they're just aware of how important that is, to the mind and body, so to speak. So
Yes,
um,
absolutely.
yeah.
So, did you know you wanted to be a doctor from early on? Were you 5 or
No,
10 and that was
I actually graduated from high school and remember saying, "Oh, I'm so happy I'll never take another science class again," which is hilarious because I now do a lot of clinical and basic science research, and I'm an orthopedic surgeon. But when you're younger, my dad was a doctor, is still. He's an ophthalmologist, and I just kind of decided I didn't want to be a doctor. Maybe, I don't know, maybe because he was. I'm not sure, but I just kind of wasn't a thing I was going to do. And then in college, I studied nutritional science, and I loved that. But I still liked anatomy and things like that, and so I kind of gravitated to science anyway. And ultimately, I went to medical school thinking I wanted to be a pediatrician. I love kids, but then I realized I didn't like that field. It was either kind of sometimes boring or just kind of, well child visits or really sad. And I really loved procedures and doing things. And selfishly, I mean, I will say I think primary care is incredibly challenging, and primary care doctors are so smart and work so hard. But I couldn't do what they do. It's just so much of it is trying to change maybe people's lifestyles or modify things with medications when you can. But like, it's just, there's not that same maybe somewhat selfish gratification of making people better by fixing things that you can fix.
No, nothing wrong with that.
Yeah. And so I think most orthopedic surgeons will tell you they really like helping people be more functional. And that is really rewarding. And it's so important for people to be able to continue to move and exercise as they get older. And we can't fix everything. Not everything has a surgical solution, and tons of things in orthopedics are actually treated non-operatively. Like probably more things are treated non-operatively than operatively, actually. But we can also help people, with those things too. So it's a pretty gratifying field, and I feel lucky to have found my way into it. And just, I always say sometimes being a doctor is a little bit like parenting. There are frustrating moments where you're
Oh, I bet.
wondering what you're doing. And then there are like really, really rewarding moments, like being a parent, like the frustrating ones and the really rewarding ones that just totally um, continue to keep you in it. So,
Laura's experiencing that right now.
yes,
yeah.
in the moment.
Yeah.
Speaking of children, though, you have 5, correct?
Yeah, their profiles are randomly behind me actually, and those what do
Oh,
you call
that's
those things?
cute.
I should know what that's called. One of our kids actually made that the little silhouettes
Yeah.
of our family. But yeah, so you never know what life brings you. I totally thought I was gonna just go do my career and graduate from college and then go to med school and then be a surgeon and be very, academically productive. And I didn't like have marriage and children kind of at the forefront of my mind. But then I met the perfect person who also was a widower with 3 kids and who were 5, 8, and 11 at the time. And then I married him and them. And then we had 2 more kids while I was in orthopedic during my residency. So we have
Wow.
5 kids. But I, I, I didn't have to be pregnant 5 times. I just, I carried 2 kids during my residency added. So we have 3 plus 2. So we have 5. And yeah, that's our
Busy household.
yeah. And my husband is also an orthopedic surgeon. So none of our children want to be doctors. Yeah. But
Yeah, that's
yeah,
always
so that's
interesting to
us.
see what they
Yeah.
choose.
Yeah.
Well,
Mhm.
okay, I want to talk about specifically midlife women, since
Mhm.
that's really our area of interest here. So, as we know, these from an orthopedic surgeon side, we know that as estrogen starts to decline, that all of these other things kick up in this perimenopause, postmenopause phase of life. I see it from the strength training aspect, with the frozen shoulder and just the niggles that kind of come with the musculoskeletal syndrome of menopause. But how does estrogen levels play a role in all of this?
Yeah, so it's really multifactorial. I think, like we know from animal and human studies, that in the absence of estradiol, whether you've had your ovaries removed or you've gone through natural menopause or you're taking medications blocking the effects of, estrogen, you're in a more inflammatory state. There are cytokines, inflammatory markers that are more elevated in that state. There are estrogen receptors, of course, throughout the body, on your muscles, on the lining of your joints, on your cartilage surfaces, in your bones. And all of these things are impacted then. So you have like a more elevated inflammatory state. You don't have the sort of muscle repairing and maintenance effects of estrogen. So it's harder to maybe build or maintain muscle, and you lose some muscle mass. That, of course, affects your metabolic health some. You have um, osteoclasts, which are the cells in bone that generally break down bone, being like living longer. They're not being inhibited by the estrogen, and so there's more breaking down of bone than there is building. So you have some accelerated bone loss in menopause. More like 2% bone loss per year as compared to 1% prior to that. And then in your joints, you get this greater level of inflammation, which ultimately, plays out in women over 50 having a much greater chance of having arthritis than men over 50, especially in the knees, because, the cartilage gets thinner faster, the lining of the joint is more likely to be more inflamed. And then in shoulders, which is a long time area of interest and research for me, of course, frozen shoulder is almost not exclusively, but very much a disease of women between the age of 40 and 60. And we know that the lining of the shoulder joint has estrogen receptors. We know that estrogen inhibits cells called fibroblasts that thicken and stiffen the capsule of the joint. So we know that at this point, I think it's pretty well accepted that frozen shoulder is also, or adhesive capsulitis is a condition of perimenopause and menopause. So that's a very long answer to your question, but all those things are kind of, going on.
Okay, so I'm going to tell you something that I used to believe before I knew what the musculoskeletal syndrome of menopause was.
Mm.
And I thought as a strength training coach that, a lot of these, what I would call weak links, the rotator cuff, the foot stabilizers, things like that women just kind of neglected. And in most programs, they get neglected. So
Mm.
I just assumed at the time that this was more weakness from not strengthening some of these muscles that was kind of kicking up this rotator cuff stuff. Which may be not helping and adding to it, but the role that when I learned about this, I was like, oh, okay, there's more to the story.
Yeah. I think now also to complicate things, as people, men and women, get to be over the age of 50, you could also start to see, rotator cuff tendon partial tears becoming full thickness tears. But I will tell you, I have studied hundreds and hundreds and hundreds of women with thousands probably of women with frozen shoulder. And usually when someone presents with a frozen shoulder, it's really uncommon to also have a rotator cuff tear. But
So
they
different.
present very differently, they act very differently. And
Yeah.
I kind of think of it this way. It's kind of like when you're under 50 and someone has chest pain, you're like, oh, it's probably not a heart attack, it's GERD, whatever. When you're
Yeah.
under 50 and you have shoulder pain, it's probably not a rotator cuff tear. You might just have some
Yeah.
bursitis or impingement, or if you're stiff, a frozen shoulder. But when you get to be over 50, you're kind of like, that could be a rotator cuff tear. Or if you're stiff,
Yeah.
more likely to be a frozen shoulder. But, age actually has quite a lot to do with our differential diagnosis of shoulder pain. But so men and women both, we do start to see, like, that's kind of the first decade where you start to see rotator cuff tears. But again, the frozen shoulder really starts to crop up a lot more, beginning in the 40s, earlier than rotator cuff tears.
Wow. Okay, so if we're looking at sex differences, you mentioned some of them that for the knees, that men
Mm.
present these symptoms later on, which is just so par for the course with everything else. Are there other sex differences that you see as far as when women present something and when men present the same thing?
Yeah, well, kind of arthritis in general, there are some studies that I'll kind of like generalize, but like between the ages of 50 and 80, women kind of have like in general like a 35% greater chance of experiencing arthritis.
Mm,
That difference is really, I would say, most pronounced in knees, maybe followed by hands. It's not as big in hips, that difference,
mm,
but the knee joint is like, I think, one of the most disparately, affected joints for some reason. I mean, I see so many women in their 50s with, it's like clockwork sometimes. I mean, I think I was in clinic last week and I had like 5 52-year-old women with this knee swelling, and their x-rays don't look that bad, but they're starting to get knee swelling that's activity related, which is in
mm.
general, if you're getting knee swelling without an injury, it's just like activity related. You're kind of maybe doing the same amount of activity you would normally do, not more, but you start to see some swelling after the fact. That is almost always your cartilage talking back to you. Unless you had like a pop, like you tore a meniscus or you tore an ACL. But in general, activity dependent swelling in your knee is really your cartilage being overloaded. It's
Mm.
just not tolerating whatever you're doing to it. And so, you start to see this creep up on people and they're like, I didn't hurt myself. Like, what is this? Why can't I do what I normally do without getting knee swelling? And it's very frustrating. And we see it all the time. Then you get an MRI and in general, you may see like a little cartilage thinning, but it's not like there's like bone spurs or arthritis on an x-ray. And it's probably like kind of the earliest wear or degrading or softening of the cartilage. And like the very earliest form of arthritis, it's not even like the cartilage is any thinner. It's just that it actually doesn't tolerate stress as well. And it kind of compresses maybe faster from activity. And then it
Mm.
doesn't rebound to its normal thickness. Like it needs more time off. Right.
Yeah.
So, I see that a lot in women in the early 50s for sure.
So, what's your recommendation for them?
Yes, well, that is a good question. um, if you back up and look at some of the early studies of the Women's Health Initiative, which people like to complain about, but they actually collected an incredible amount of information on tons of women
Yeah.
very diligently. And one of the things you can learn from like some of that data was that there were a lot of women who presented with joint pain as one of their symptoms of menopause. One study was like 77%, like almost 80%. And then women, treated with hormone therapy that included estradiol, some studies estradiol with progesterone, but nonetheless, hormone therapy had reduction of their, number of painful joints and the severity of the joint pain. And then when they had that hormone therapy removed, there was like a rebound effect. Now, there isn't any study that shows yet or ever that being on hormone therapy helps you be less likely to need a knee replacement someday, but I don't think we've like studied things at that level or studied when you should start hormone therapy or like what dose. We have a lot of information about hormone therapy and how much it can improve your bone density and how much it can prevent fractures and reduce all-cause mortality. We have less granular data, I would say, about like when you initiate and what type and what dose and like how that might impact your cartilage health. And that is an active area of interest for me. I collaborate with some of our PhDs on this topic. But so I think it's not like an FDA indication. It hasn't been proven, but there's, I would say, circumstantial evidence, right? Like there are estrogen receptors on cartilage in the lining of the joint. We have basic science studies that show synovitis or inflammation of the joint can be ameliorated with estrogen therapy. We know that women have this divergent like risk, over 50 of more rapid cartilage thinning and arthritis. There's probably something about hormone therapy and the right timing and dose that will ultimately like bend that curve. That's not a solution for everybody because not everyone can use hormone therapy. And of course, I have many patients on aromatase inhibitors who are experiencing increased joint pain, associated with their necessary treatment. So, but that's one thing. There are very few things that slow progression of arthritis. One of them is weight loss, if you have weight to lose. So losing 5 or 10 pounds will actually take quite a lot off of your knees and make them feel a lot better. For people who are obese, even your non-weight bearing joints are more prone to arthritis, probably because of an inflammatory state. And that's, I think, one of the beauties of use of medications like GLP-1 medications at this point. You're not only helping people lose weight, but you're reducing systemic inflammation and probably reducing risk of arthritis. And then, but for people of healthy body weight, if you don't have like weight to lose, what else can you do? I think there's reasonable evidence behind collagen supplements. I think that certainly you can always utilize anti-inflammatory medications, but there's pretty reasonable evidence for using turmeric as an alternative if you don't want to be on those all the time. I think choosing your activities wisely, if you're someone where your activities of choice are causing swelling, like maintaining strength training exercises, I think that's good to do. If you love to play pickleball, but every time you play pickleball, your knee swells, you're probably advancing your arthritis a little bit with every episode that creates swelling. So you need to either back down on the dose or duration or something, or find alternatives. So sometimes there's some modulating of like how much of something you do, how often you do it. You don't want to like exacerbate things, but you kind of get into the land of, symptom management, which might include also different types of injections, PRP, things like that. So I could go on and on, but I don't want to, you guys have questions.
Well, I'm curious, and I'm glad you brought up collagen because we've had lots of experts on the show that it's, ones that are pro and ones that are against and say it's totally worthless, and other ones that have done their own research on it and are on these studies that say, yeah, it's actually been shown to help with XYZ. So you're a fan of that. You think that it's potentially helpful.
Yeah, I will say I changed my mind about it probably a couple years ago, I'm constantly reading studies. And when I was working on my book, I just revisited all the literature and went down so many rabbit holes about it and read so many studies. And I think that like the basic science behind it is reasonable. There isn't a study that shows it like necessarily slow. It certainly doesn't reverse arthritis. And actually, like, to be clear, nothing actually like reverses arthritis. That's one of the annoying things about arthritis. Sometimes I tell my patients it's like gum recession. If you go to the dentist and you have a little gum recession, you're never going to have less gum recession, but you'll be happy if someone tells you it's not any worse than the last time you went. It's still going to be there.
Yeah.
And it's also not something you can scrape out. Like there are so many people that get unnecessary knee scopes for arthritis because I don't want to say that someone is doing unnecessary surgery, but they want the surgery or they end up having the surgery because they have the sense or belief that arthritis can be scraped out of their knee. And it's kind of like a double negative. Arthritis is generalized thinning of cartilage, and you can't remove something that's missing or thinner, right? We don't have that way of magically adding back thickness to cartilage everywhere. So what collagen studies show, is basically a lot of them show decreased downstream breakdown products of cartilage. And meaning like that should suggest you're kind of maintaining the health of your cartilage more, right? And so I don't think, I think if someone tells you take this collagen supplement, you're going to, gain more joint space and thicken your cartilage. Like that's not true, but I think it does help with maintenance of cartilage health, like, maintenance of what you have. And of course, as you probably know, there's like hydrolyzed and undenatured collagen.
Yeah.
And there's also studies on the different types. The hydrolyzed ones are digestible and absorbable, whereas the, UC2, the undenatured collagen type 2, which is the primary kind of collagen that's in our smooth gliding cartilage, it seems to have like a different effect, like something that is more of an oral tolerance effect, exposure to your GI tract. But same thing, the measures are like looking at kind of breakdown products of your cartilage, right? Not whether or not you develop arthritis or not. So no, I can't say that taking collagen definitely slows the progression of your arthritis or definitely makes you less likely to need a knee replacement later on in life. Those studies don't exist, but some, again, pieces of scientific evidence to kind of suggest to me that I do think it's beneficial. And I like to use a collagen supplement that combines type 1 and 2 collagen, because I do think there's also strong evidence for hydrolyzed type 1 collagen supporting bone health. And, I'm kind of just lump them in together in my coffee. So
Yeah. And there's never like just a straightforward answer most of the time. It's, I love how you explain that, because there's a lot that goes into it other than just saying, yes, it helps or no, it doesn't.
Yeah. And I definitely don't think it hurts. If you ask, I think it's reasonable enough that I use it. And then people always ask, well, like, what collagen do you use? I'm never trying to like promote a product, but people always ask that. So then I tell them what one I use, but I don't want them to like think they have to get like that specific one. But I do like it because it does have type 1 and type 2 collagen in it.
Well, now you have to say what it is, because then we're going to get head
I
up.
use the Healthy Bones one, Healthy Bones
Okay.
Total Body one, the Healthy Bones Total Body. And it's really dissolvable, and you just put it dissolves. It's sort of fun to watch, actually. This is such a strange thing to say, but just for fun, you make your cup of coffee, and then I heat up my milk, and then I like a ton of milk with really strong coffee, because coffee I feel like is like I'm getting some protein and some calcium, and coffee has other good factors, but you just like dump this scoop, and it's like this little white mountain, and it literally disintegrates into it. You barely have to mix it. And it is weirdly satisfying to watch. You should try it.
Okay. I have collagen, and it literally it's sitting in a cupboard, and I never get it out. And every day I'm like, oh, I should get out the collagen. But
well, I
here's
think
my
that
reason.
coffee is a good option, because people, like that's something that most people do every day. And I also
Just
think,
get it done.
well, yeah, like there's other great things about coffee too, but it's so easy to add in. So
I'm with you on that. That's what sold me. I'm like, now I'm going to be very consistent with my collagen.
So,
it
okay,
also makes it slightly smooth. It's kind of weird. You can try it.
Well, now you've intrigued me. Now I've got to go like do this whole procedure and see if it's as
just try it
mesmerizing as it was for you.
First thing in the morning, I kind of
I love it. So, okay, I want to really dive into, because these are the questions that come up all the time. Jump training. Now, this is how I found you.
Yeah.
And I actually got served up on Instagram. Laura was just asking me, how did you find Jocelyn? I said, she got served up. And then I saw that Dr. Vonda Wright followed you, and all of these other leaders in the space. And you were doing a jump of how much impact from, you had your tape measure and you were jumping off of that.
So funny. I didn't realize how much that would grab people's attention. I just,
it did.
So it's a little 8-inch drop jump. And I didn't make this up. There's a researcher. First of all, we know that impact creates a stimulus to our bone that increases bone density, especially at our hips. So like in general, strength training does a little bit more for our lumbar spine than it does for our hips, although it does something for hips too. But the impact training is primarily affects our hips. And so the specific study of the amount of impact you get with an 8-inch drop jump and a rebound came from a study done by a researcher named Tracy Clissold and her group, or the group of researchers she was working with. And I just wanted to show people, like, you don't need a ton of fancy equipment. Like, I was like, look, here's my ruler. It's 8 inches. Most steps are 8 inches. And I was just in my backyard, which is frequently where I make little educational videos. And I just was like, this is all you have to do is like jump off this jump and do a jump landing. And I mean, it's kind of like, I think sometimes people don't realize that you don't need a lot of stuff. Sometimes you do, like if you want to go do like heavy lifting, which I also like to do a couple days a week, but jump training you can do like anywhere. Plyometrics you can do pretty much anywhere.
Yeah. Okay, so we have the jumping, and from the Tracy Clissold's, from her research, she recommends landing with like a straight leg, like not really absorbing the bounce. Is that more what you were doing, or
kind of like the softer the knees or the more like kind of toe to heel, you would be absorbing some of the load, but you're trying to drop and then do a rebound, which actually, if you haven't done that in a while, like so many people just drop and hit the ground and like don't actually know how to rebound, like a kind of a plyometric thing.
Yeah.
And so I had a lot of people write to me, oh, I forgot how to do that. And I just think that people like forget how to skip and hop, or people forget how to jump rope. And so I don't want to say I'm immature, but I love doing like, I was a gymnast, so I'm always like,
this is the gymnast in you coming out.
I like doing things. If I'm at the playground, I do some pullovers, or I do the monkey bars, or I like jumping around. But I noticed that, like I shared a few months ago, I almost forgot how to do the monkey bars I almost forgot. I hadn't done it in a long time. It just felt really weird. But I think jumping is like that. If you haven't done like a jump landing in a while, it feels weird and you forget how to drop and do a rebound. And so you could start less than 8 inches and try it. Or, actually that same group did just like a big squat jump with the rebound, and you still get that effect on the second, on that rebound jump. But I thought it was more visual for people to kind of do it off of a step. So
yeah, no, it was great. And I love it. Like, I remember this was years ago when my daughter, who's now 21, when she was, I think, in probably kindergarten. And there were monkey bars. And at the time I wasn't doing any lifting. I was doing triathlon, and I just didn't do any lifting with it. And I tried to do the monkey bars. I thought my arms were going to fall rip out of the socket. I was like, this sucks.
It's because people don't use their lats very much.
Clearly I wasn't. It was terrible. So, okay, so we have the jump, and then other options. So we know that, we're looking at, and not that osteoporosis doesn't happen anywhere else, but we get tested at the wrist, the femoral neck, and then the lumbar. So if we're looking at like the wrist, so if we were doing overhead, a barbell overhead press, we're loading the wrist. That's one way where we could load the wrist. But what are other ways that you could add more dynamic to it?
So I think that people should, try to load your wrist. Now, the funny thing about your wrist, so like, first of all, when you talk about the wrist, we're usually talking about the distal radius, the wider bone here. Of course, there's smaller bones in the actual wrist here, and your ulna is small. But the thing that people break is the distal radius. Of note, like the first peak that we see in distal radius fractures in women is like actually in the 50s. And it's kind of like a canary in the coal mine situation, because if you fall, like same level fall and break your wrist, it's a good time to get your bone density checked, because that may mean you have like lesser bone density in some other places as well. And for instance, like there are some studies that show if you break your wrist, you have a 40-50% greater chance of having a hip fracture later on than someone who like has never broken their wrist, because it's an indicator maybe of your bone health, or maybe your likelihood of fall, who knows. But so wrist fracture can be, I always tell people, the silver lining of a wrist fracture is this can be a bit of a wake-up call. Like maybe you just have some osteopenia. Also, it's so often happening to people who are like in their early 50s, when maybe they're making decisions about like hormone therapy or not, which is prophylactic against osteoporosis. So not that I want people to go around breaking their wrist, but like if that happens to you, like take advantage of that situation, go get your bone density checked, pay attention. But anyway, the
Yes.
interesting thing about the wrist, it doesn't have like a ton of large muscles attached like right here. So like in
Yeah.
addition to like impact, strength training, carrying things, putting load across your bones strengthens your bones, but also just like the tugging and pulling of large muscle groups will strengthen and remodel bones, like your deltoid, your biceps, your triceps. But this is kind of an area where like a lot of tendons and nerves and vessels cross over. There are some smaller muscles that attach here that, like pronate your wrist and move some of your fingers, but like they're not like huge muscle groups. So I actually think if you, wanted to like maybe try to impact your wrist bone density, that doing some load bearing on it is good. It could be, as you said, an overhead press, which of course is part of the lift more protocol and also is going to load the rest of your skeleton because it's you're pressing it overhead. But I like to encourage people to do planking, walkouts. I shared a video the other day of like kind of a drop onto your arms.
Yes, I saw that. I loved it.
Or
Great
you could do
option.
like, like when you're a gymnast, we used to do like handstand pops, but people aren't going to run around doing like little jumps and handstands like when a gymnast. But I love to do handstands. I do them at the gym against the wall with my 17-year-old son. and
Yeah.
But you could do so push-ups or load bearing. Honestly, pushing a lawnmower, as someone suggested the other day, like that's some load bearing on your wrist. If you can't do like, you could do clap push-ups, but you have to be pretty strong to do that. So you could do that on your knees where you just push and then land, like a knee push-up with a push off. I kind of showed you can do like little drop onto your hands from a yoga block, or someone suggested PT for women on Instagram suggested doing like a bear walk to drop into a push-up position, like a plyo push-up. I love bear walks because that's a core exercise, but you're also weight bearing. And I love single leg walkouts because it's like a balance and core thing. You walk out, you walk
Yeah.
back in, or ball walkouts with a plyo ball. You're basically
Oh, that's
walking
hard.
in. Yeah,
That's tricky.
yeah. I think a lot of the things I like to do are remnants from old gymnastics things, but you can apply them to non-gymnastics people too. It's just simpler versions. And so I
No,
think it's good to put some weight on your arms, even
yeah,
if it's
for
not
sure.
pressing. Yeah.
I'm super impressed with that because I always get asked, well, what do I do if I have osteoarthritis in the knee and I can't jump? And there's all these other options that, okay, sure, you're not going to, if you can't jump, but you can load the wrist, how you said. You can still load the spine, but what
Mm.
else do you have for women that have
Can't jump.
osteoarthritis and they can't jump and they feel left out of the party? And I never want
Yeah.
anyone to feel left out of the party.
Yeah. So this is where like what you can tolerate comes into play, and something is better than nothing. And like the concept of it, I don't know if you know the term weight bear is tolerated that we use in orthopedics. Like I have a nerdy hat that says it, WBAT, which I'm going to make some t-shirts of. But some of my lady residents, we have a little WBAT club, we call it. But anyway, so we're obsessed with weight bear is tolerated. It's a fun acronym for something we tell people to do after surgery. Like if it's safe to put weight on your leg, we say, weight bear is tolerated. But it's a term that I think people can apply to so many things. Like what can you tolerate? Like
Yeah.
if you've got some arthritis in your knee and you can't jump for impact, you can do heel drops probably, right? Like that does create some of that impact. You can do using like a rebounder or a mini tramp, jumping on there. It's not as effective for stimulating bone density at the hips as jumping on the ground is, but it does something, and it's better than not doing anything. And likewise, you can jump in a pool, like kind of like where some of your body is underwater, and so there's some resistance to get out of the water. There's some impact, although diminished, on entry again, and that's better than being sedentary.
Nothing.
It's not as much as jumping on land. So like find what you can do and do it and keep doing it. And it's not going to help you if you have really bad knee arthritis and you're like, I'm going to jump because someone told me I need to jump, but then you have swollen knees for 3 days. Like that's not a good outcome for you. So I just think everyone needs to like listen to their bodies. Not everything is for everyone, and that's okay. And there are modifications, and just the hard thing for women, especially in your like say 50s, is you're trying to navigate doing exercise to maintain your bone density, but at the same time you're at risk for arthritis.
Yeah.
And so you have to listen to, I think, your joint pain or knee swelling, and modify. So like squatting, if you have bad knees, I mean, I don't think you have to go past 90 of knee flexion. So maybe you can do that, or maybe you do your squatting with moderate intensity, not high intensity. Maybe you can do higher with deadlift. And if you don't have shoulder issues, maybe you can lift heavy with overhead press. Like you don't have to go high, and you have to listen to whatever issues you have going on. And I always give the example, I actually am never going to be a high intensity overhead presser because it always gives me a recurring injury or tendonitis or whatever. And so for me, like overhead press forever for my whole life is always going to be like no more than moderate intensity, because I know that about me.
Mhm.
And that's fine. I'm still contributing to my maintenance of muscle mass, and moderate intensity lifting still helps with bone density. It's not as helpful as high intensity, but high intensity isn't helpful for you if it takes you out for 3 weeks and then you can't do something because
Yeah.
you have tendonitis. So I just think people need to listen to themselves and not feel excluded if they can't do like the hardest version of everything. And I mostly try to share with people data and options, and I think exercise can be fun, and I I I can't stand to not exercise, and I hate it when one of my patients who likes to exercise feels like they can't exercise because they're
It's the
limited. So
worst.
I hate it for them, and so I just constantly try to think of workarounds. And like for so many of my patients, okay, if you can't, they're like, I can't run anymore, I can't jump, like what can I do? A lot of them I refer to, like, if they have good hip mobility, like rowing is a great option. It's
Yeah.
actually quite tolerable to arthritic knees, and because of the forces you're applying to all of your muscles, actually has some, it's a low impact, on your knees type thing, but still actually has some benefits for bone density. So I just think we constantly have to find ways for people to keep threading the needle between joint pain and maintaining their muscle mass and maintaining their bone density.
Okay. So this is the last question on this, but well, first of all, I have to say I had knee surgery 8 years ago where I had a full meniscus root tear. So I was non-weight bearing for 6 weeks. It
Touchdown
was
weight bearing 6 weeks.
the worst. But I would go and sit at my physical therapist's office and they had the arm bike. And I would
Yeah.
sit on there for 45 minutes. The crazy ladies in here again doing sprints on the arm bike. It was all
Well,
I could do. I was like, I
you
have
should
to
have.
move somehow.
It's too bad that we didn't know each other then, because I could have told you about 3-limb biking, which is where you get on an air bike and you put your injured leg on a leg rest, and then you
Yes.
bike with 2 arms and 1 leg.
Jocelyn,
Oh,
I'm so mad. Well, it
okay.
saves
I'm
everyone
gonna
else.
have to work around.
And I think that's the best way to get your heart rate up, when you have like one leg that you can't like do cardio
Yeah.
with,
Oh yeah,
because
I
the
had to get
arms
creative.
don't get enough. Or
Yeah.
you can do a ski erg if you have the ability to balance on the one leg.
Yeah. I mean, I eventually got in the pool and just put a buoy in between my legs so I could
It's
just
maddening. Yeah.
it's
The
maddening.
meniscus root tears are really, also, by the way, I think people need to choose carefully, because if I don't think you had arthritis, but if you already have some arthritis and you tore your meniscus root by like simply getting up out of a chair or something like that, that means the tissue quality isn't good. And then you get into the disease of treatment, because sometimes people are just having a root repair, touchdown weight bearing for 6 weeks, their muscles atrophy so much on that leg. Actually, you will get focal loss of bone density on that leg that will take a couple of years to return to normal sometimes. And it's not benign. So it's like it's you have to choose wisely if you're going to have a root repair, because that
Yeah.
6 weeks on crutches can, and you're already in a situation, like let's say you're a woman in your 50s where you have a hard time building muscle. So you
Yeah.
get atrophy and disuse, and then you have to, disuse is hard.
Bad.
It's true. I hate to put weight bearing restrictions on people, but that's one surgery where I tell them you can't put weight on your leg for 6 weeks, and so it's a
Yeah.
big deal.
Yeah. No, my doctor, I had hospital for special surgery, did my surgery. And I mean, he was like, I'll take you. I just finished an Ironman, so I had like a bunch of things that way. But I mean, he was even hesitant because he's like the success rate and all of these other things that come with it. But I was desperate. But
Yeah.
if we move on to this lifting heavy. Okay. So I partner with two women that really, really want women to lift heavy. I lift heavy, although it looks different now because my back doesn't love back squatting really heavy.
Mhm.
So I just don't do it. I do it in other ways. But let's go over
Same with
when you
me.
said the high intensity, you're meaning 80% or more of your one rep
Right.
max.
The
So
high
let's
intensity
cover those.
is that 80% single rep max, which since most people don't know their single rep max, I try to translate what that means. It would be
Mhm.
like the weight that you could do a set of 4, 5, or 6, where like the fourth, fifth, or sixth is really hard for you, and it's the last one you could do with good form. So that would be
Mhm.
like and then you have to rest before you do another set. That would be like that version of your 80% single rep max. And I do that for certain things and not for others. And I think that if you look at studies of less intense lifting and more intense lifting as interventions for women, specifically menopausal women, even with osteopenia, there is more return on investment, meaning you do gain more bone density, especially in the lumbar spine, with the higher intensity lifting, the lift heavy.
Mhm.
But even within those studies, of course they show safety, which is great. Like we have the Lift More trial showed safety in these women who are average age 65, osteopenic. There weren't any injuries. But those are studies and they're not real world, and people are screened out because they had that root repair or can't do something because of some pre-existing injury or whatever. So in real life, we're not subjects in studies that met exclusion and inclusion criteria, and we
Mhm.
have things. And I think the messages are very good that heavy lifting is the most effective for building and maintaining bone density and muscle mass. Or at least for bone density. But there are also benefits of the less intense lifting. You have to obviously do more repetitions, not less, and the return on like the gains in bone density isn't as much, but it's still a positive. And
Mhm.
so I mean, I see people all the time in clinic, but if I told them to go do that, they would be like, that would hurt my knee because I had a root repair, or I had my rotator cuff repaired last year. I can't do heavy overhead presses. And so we can find workarounds and things like that. Maybe you can do more farmer's carries with something heavy, or maybe you can do, like, I prefer hex bar squatting over back squats, more or less,
Mhm.
kind of
Yeah.
thing. But yeah, so I think real life doesn't always, like I said, match these inclusion exclusion criteria, and people have actual issues they have to work around. And so I just don't want people to feel excluded from the strength training process or the benefits of it, or think that if you aren't doing the highest intensity, that it's not worth doing, because that's also not true. In a perfect world, if you can do it, I think it does have more benefits. Yeah. And I
Yeah.
do it a couple days a week, like I said, but not for overhead press. So
Yeah. No, that's
anyway,
good. And it gives women permission to say, "Hey, you know what? It's great if you can lift heavy at this 80% one rep max or 4 sets of 4 or 5 sets of 5 or whatever you're doing.
yeah.
But if you can't, then there's an option, and thank goodness there's these other options that still can
Hmm.
give us almost as much of that
Yeah, just
benefit.
not
But can
quite as
we
much.
can we do the unilateral? Can we do unilateral where you're not loading as much, but you're still doing 4 reps where you're really taxed and it's just as heavy, but you're just working one leg instead of bilateral?
Yeah, I think that actually is sometimes better at identifying asymmetry.
Mhm.
I mean, sometimes we're compensating on, you know,
Yeah.
um, we all have a dominant leg, for instance. So yeah, I think that there's definitely benefit to unilateral strengthening, and also certainly helps with balance and things like that. So yeah, you're still either doing a high intensity on that one leg or moderate. It's just you're doing it one at a time. It takes twice as long. I think that's not an issue.
Yeah. Okay. Well, lots of options, ladies. I hope you're taking notes.
And something is better than nothing.
Oh, I
Yes.
always think something is better than nothing. I mean, the classic example is, well, I don't want to call walking nothing, because walking has real benefits. Like, certainly studies showing that walking, regularly reduces your fracture risk, even if it doesn't necessarily improve your bone density dramatically. But I just think people also need to think of use as the opposite of disuse. I mean, I don't want to say like walking is nothing, but it's not that something is better than nothing. It's just that you're using and weight bearing on your lower extremities. You're maintaining your balance, your movement patterns. The opposite of not walking and not standing is being on crutches. Like you
Yeah.
had your root repair and you were on crutches for 6 weeks. If you had even just an ACL reconstruction, and so like let's say you're on crutches for a period of time, and then you get some atrophy and you have to build your muscle back up. One of my good friends, who's chief of orthopedics and sports medicine at University of Wisconsin, Tammy Scarpella, has done some work on this. Like even a person who had an ACL reconstruction, 2 years after their ACL surgery, that's how long it takes them for their bone density in the surgical limb to like fully recover all the way across the length of their femur. And that's from a short period of disuse. So, or if you were an astronaut and you're not putting any weight on your legs, you develop osteoporosis at a ridiculous rate. So weight bearing on your limbs, whether you're walking with or without a vest, or jumping, or if you're on your arms, if you're load bearing, like these are things that are the opposite of disuse, which would be in an extreme version being an astronaut or being on crutches or something like that. So
Yeah.
yeah.
Bless the astronauts. Bless
Yeah,
them.
that's why they have a special thing. They have a special resistance training thing on the ship it's not weights. It's like basically super resistance bands. So they're like squatting, and they still do resistance training like multiple hours a day when they're on missions in order to try to stave off bone loss, actually.
Yeah.
So even the astronauts are doing strength training to maintain their bone
Yeah.
density.
You have to.
Going back to the ACL, what factors can contribute to ongoing atrophy and imbalance? And
After
what are the
surgery.
most, after a full
Mm.
ACL and meniscus tear and reconstructive surgery, what are the most effective ways to restore full strength?
Well, I think one of the key elements is when you tear your ACL, the knee swells, you get fluid in it. And then after surgery, there's usually swelling in it too. Whenever you have swelling in your knee, your brain will like automatically shut down your quad. And you get what's called quadriceps inhibition. And so someone will come in and they like won't even be able to lift their leg off the table, or they can't walk because their knee would buckle. And so the longer that goes on, the more atrophy you get, the more of a hole you have to dig out of. And so I actually like to, in the really early post-op course, after my patients, like the first visit, if they have swelling in their knee, I actually stick a needle in it and drain it out, and they can immediately activate their quad. Like it's an immediate difference. Like someone who couldn't lift their leg up can lift their leg up. Someone who couldn't show me active hyperextension can do it. It just immediately helps them restore their function. So that's one thing. Getting the swelling out of the knee as soon as you can so that you can get your quad activation back. And the sooner you start to activate your quad, the less atrophy you're going to have. And then, like restoring normal gait as soon as you can. So starting to walk normally. And then it's just a matter of like being really regular about like with whatever you can do. I mean, we obviously give parameters usually in the first few months. We don't want you doing certain things. We start to add in like lunging and squatting and leg press. And I think the number one mistake people make in rehab is they think that you do physical therapy only when you're at physical therapy, but it's so important to, just like if you were going to, like if you don't work out one day a week, your physical therapy like kind of becomes your workout. And I tell people you need to be really diligent about this. You need to do this like 3 or 4 days a week for the strength training part, and just treat it like it's your exercise routine. And I think that is kind of one of the major reasons why people can kind of get prolonged atrophy is they're just not being diligent enough about it, or maybe a lot of people don't even understand, like if they don't think about it in that way, but it's kind of your workout. And I had this hip surgery last July, and I was completely obsessed with rehab. I took 7 weeks off of work, and I think the early phase can be kind of some of the most important phase to sort of try to like not get so much atrophy. That's what I was doing, the 3-limb biking. I would do it like 2 hours a
I'm
day.
jealous.
Yeah. See, and I
It would have saved me a year of working back until I got, I mean, I think it was more like 18 months before I got full strength back in that leg. Man, that would have been helpful.
well, what if it's been a couple of years and you're doing pretty good, but you're not 100? What are the things that you can do to like feel
Mhm.
like you're running again and you are regaining, like you're back to 100%?
Yeah. So most people do end up losing. It's common to lose about 10% of your strength in the leg that like had the
Mhm.
surgery. That's a good. We like people to get to 90% limb symmetry.
Okay.
You can try to use blood flow restriction therapy later on if you're just kind of like struggling to like get stronger. That can be an option to kind of help with muscle hypertrophy. Um, Return to running is, well, one thing that can make that hard is if you do have any residual swelling. Hopefully someone doesn't, but I actually have people work with like a running physical therapist and have them do like a gait analysis and sort of just make sure that they're striking evenly and their stride length is even, because people really sometimes up until a year will have this altered gait where they spend less time on the surgical leg and more time on the other leg, and it's just they're compensating. And so I think sometimes we need to work on that.
Do hormones play a part in recovery for women in
So
period?
interesting. There's some mixed data on estrogen. This is a whole massive topic about estrogen and hormones and why do girls tear their ACLs 8 times more than boys. And um, this is an area of active research for me and a couple of our PhDs that I work with. And we have a study upcoming where we're like actually currently looking at this. But yeah, there's some theory that estrogen makes the ACL like more lax and more likely to tear. On the other hand, there's some theory that it also kind of helps to organize the fibers of the ACL. Uh, Also, the low estrogen state maybe of the cycle may be associated with more like muscle fatigue. So, is it, are you more likely to tear your ACL when you're in a low estrogen state or a higher estrogen state? That's something that we're trying to get to the bottom of with these kind of 3D MRI models we make of knees and have people do this jump task, and then we measure how much their ACL stretches and compared to hormone levels and things like that. So we're actually actively studying that, but it's more of it doesn't seem to be so much of a factor in recovery. It seems to be more of a factor in, or something that we need to understand better in terms of a risk for injury. Because unfortunately, someone asked me like, why are you so interested in midlife women's joint health? And it's like, well, I'm interested in the full span of women's joint health because girls are 8 times more likely than boys to tear their ACL. If you tear your ACL, you're also more likely to get post-traumatic arthritis, and that's another area that we study. But then, women are more likely to get arthritis regardless as they age. So, for a teenage athlete who tears their ACL when they're 16, when they're maybe coming up on 30, they may start to have some arthritis in their knee from post-traumatic arthritis, and then you may arrive at adulthood and be even more at risk. So for people who are teenage athletes who tore their ACL, they're really high risk for arthritis as they age.
Wow. Okay, so if we move on, and I'm glad that you mentioned weight, Bess. So there's a lot. I've now been online for 4 years, and the last year the space has gotten really wow. Wow. All I can say is there's really not any like there's pros and cons to everything. What do you like
Yeah.
to do? What works for
Yeah.
you? But people get so hooked up on no, absolutely no weight vest or
Yeah.
yes, do the weight vest. And I'm like, why is it that it shouldn't be that big of a deal? I'm curious on your
Yeah.
thoughts
As
on
you can
all
tell,
of this.
I'm a big kind of, it's not
Middle of the
always yes or
road?
no. There's nuance. I'm a nuanced person. There's a lot of
Yeah,
nuance.
me too.
Um, so I think I don't ever want someone to think that wearing a weighted vest is the thing that's gonna, improve or restore or maintain their bone density. And the studies that looked at that are limited. And there's a study that's a subset of a study. So it's like even a smaller part of a study that included women that were doing other things, including some strength training and jumping and stuff. And so there's this one study that showed some improvement in bone density, but it was like a component of a program and a subset of a group of women. So it's not something to necessarily hang your hat on. But I have a weighted vest and I have a rucksack. I actually like a rucksack better because I feel like I feel like it's more of a core activity because you're kind of like stabilizing it. But I don't necessarily use it for maintaining or building bone density. It adds to my cardiovascular exercise. I put it on when I walk my dog, or which is early in the morning and late at night,
Yeah.
and it's a nice add on, and I think things do add up. So I don't think there's any definitive study that shows that walking with a weighted vest is definitely like increasing your bone density. But it
Yeah.
is taking your walk up a notch. It is a little bit more load. There's again, I think these things are cumulative, and it's more use than less use.
Yeah.
Um, Now, the conundrum I kind of struggle with for some people is if you have some knee arthritis, and we're telling you if you lose 5 or 10 pounds, your knees will notice a difference and they'll feel better. Do I want to tell someone who's dealing with knee arthritis and trying to find ways to maintain their cardiovascular activity and not get knee swelling? Do I want to tell them to put on a 10 pound or a 5 pound, 13, whatever? Most of them are,
Yeah.
you can get 5, 10% of your. Do I want to tell that person, I just told you your knees would feel much better if you lost 5 or 10 pounds, but put
Yeah.
this vest
Right.
on? So I kind of don't. If I'm at the same time, if someone is like kind of at the cusp of like, you know what, if they've said to me, my knees feel so much better when I'm 5 or 10 pounds lighter, and they're trying to walk for cardiovascular activity, that's probably not the person I'm going to tell to put on a weighted vest.
Yeah. So as with
But for someone
anything,
whose knees are feeling good and they want the added cardiovascular exercise, great. And some of the studies show like it did help with strength or maybe like parameters that would be associated with fall risk, like balance and things like that. So
yeah.
it's in the category of I definitely don't think it hurts you, and there are definitely some positives. It's just I wouldn't portray it as this is the way to like this is the path to preventing. It's not the path to prevent, to
Yeah.
preventing. It's not enough by itself to prevent osteoporosis.
Just a deeper, I mean, there's always a deeper conversation than just weight vest, yes or no. But it
Yeah,
is, it's funny. I want to say the internet needs to chill. Chill.
yeah. I don't think we should villainize people who are supporting them or yeah, it's almost like become a are you a vest person or not? And I think it's certainly getting people out and walking, and I see a lot of women at my YMCA, which is where I go do my heavier weights. Doing like incline treadmill walk with it on. I think they're getting a really good workout, and it's
Yeah.
another option. Some of those people are probably people who maybe aren't running anymore. Maybe that was bothering their knees, and so they're doing that, and they want the exercise. So I do think it has benefits for sure.
Okay. So this is my last question before we wrap it up. Um, and this just popped into my head and it wasn't on the list or anything, but do you think I mean, I hear from this from women every day, and it's maybe just because I have my app and I have a lot of women on there and different courses and everything like that. Do you think that we have, or the internet, having access to every different specialist and strength coach and this has made it more confusing for women, where I'm like, for me, I don't think it has to be that deep pick and choose, like, sure, you should do a little bit of this, a little bit of that,
Yeah.
but the perfect prescription doesn't exist because it's not unique to you. But what are your thoughts on that? What do you
Yeah,
think?
I do think online resources could certainly be lacking in the nuance. And yeah, I think a lot of people are very um, just kind of black and white in their opinions. And it's, yeah, you could easily find one person saying one thing, one saying the other. I mean, we hear all the time about what to eat, when to eat it, and
Yeah.
you should be jumping or you shouldn't. And I struggle with that a little bit because I do want to share good information, and and I've enjoyed sharing information, and I try to respond to anyone who asks me a question with the nuance related to them. But it's hard, even if someone is giving me information specific to them, if you're not actually seeing a person in front of you and examining them and knowing their medical history, you can't really give the best information. So I think that yeah, people need to like still consider their own, individual circumstance, and not just put expectations upon themselves. Like, I don't think everyone needs to look at everyone on the internet and think. What I worry about it actually is people feeling like inadequate, or like I said, excluded,
Yeah.
if they maybe can't do like what someone is saying they should be able to do, and that's okay.
Yeah.
So I think people need to start somewhere, do something. Vapor is tolerated. You know? These are reasonable expectations, and you can always start. It's never too late to start. Like I like to say, like so many of the studies on even bone density are on women who are 65, and some of these studies are following people for 15 years, and reporting decreased fracture risks, and things like that. So I think the other thing people hear is that it's too late speak, and I don't ever want anyone to think it's too late. When you hear it's too late, oh, you should have had a DEXA when you were 50. You didn't get it until you were 65. It's too late for you. It's like this. I don't want anyone to like hear like fear
Yeah.
mongering. I just think like sometimes when we're saying things like current recommendations seem too late, it's more like wishful thinking. I wish people could get, you
Yeah.
know, something studied earlier, or I think it would be better if we could, that kind of thing. So I just, yeah, I think you're right. People hear stuff on the internet. It's confusing. It's maybe hard to apply directly to them. And I just think maybe look for people who are using data. I think that's good. Using research to help kind of guide what they're telling you. But yeah, there's always going to be some mixture of opinions. There's data overload, frankly. Yeah.
Yeah. Yeah, for sure. Well, I want a hat. I want one of your hats when you make
I do
them.
too. They're really cute, by the way.
My
We'll
resident,
rep
one of my
them.
residents made that for me, and she's really interesting. Actually, the two of them are really interested in this. She's actually currently studying estriol application to fracture sites. Estriol, the stuff that's in the face cream.
Yeah.
Mhm.
Yeah,
Yes.
to see if that will help with bone healing. That's one of the two residents that's in the Wabat hat.
I love it. Oh, we're staying up to date with that. I can't wait to hear that.
Yeah.
Well, Jocelyn, it has been a pleasure. I can tell that you were someone that never left anyone out in elementary school and high school. I feel the same way. This is why I want everyone to join in on the party. I'm like, we don't want to leave anyone out.
Mm.
I just love your demeanor and just how you can apply the information, but there aren't these hard, fast absolutes. I think it's really helpful for women to not feel discouraged if they don't fit that
Yeah.
mold, because a lot of women aren't going to fit that mold, including even myself, that
Hmm.
I had back surgery at 17, had, these different things that I just can't do it the same way, but I can do a lot of other things that are just as
Yeah.
good.
None of us are immune to these things. I mean, I had a hip surgery last summer, and like 9 months ago, I had a frozen shoulder, which is extremely ironic because I'm a female orthopedic surgeon and I study frozen shoulder, and I was like, I have So yeah, no one is immune to these things,
Mhm.
and none of us are like immune to aging. And it's just, I think we can try to age wisely and be proactive about our health. So yeah. But thanks for having me. It's so nice to actually meet you guys. I want to say in real life, but we're on Zoom or
Yeah,
we're
it's
on
as close to
video.
real life.
Yeah.
I'm hoping in real life one day.
Yeah, in real life someday. Yeah. Yeah.
So, okay, while we're wrapping up and we're done, we're logging off, but I want to make sure that people know where our listeners can find you. Can you share that information before we jump off?
Yeah. I mean, maybe the easiest way is my Instagram page, which is just Jocelyn_Wittstein_MD, which, full caveat, my 19-year-old daughter showed me how to use in January of this year. Uh, so, but
You're doing incredible.
she's taught me well.
Mhm.
Yeah. And then I practice full time as an orthopedic surgeon at Duke University. But in terms of like the information I try to share in sort of, data driven, digestible bites, I think, is in a lot of Instagram reels. So
Yeah, perfect. Well, thank you so much for sharing your time today. We can't wait to launch this episode. We know it's going to be a real hit for our listeners. So thank you again.
yeah, thanks for having me.
Thanks for listening, everyone.
If you enjoyed this episode, please consider giving us a 5-star rating and sharing the Body Pod with your friends.